Good evening. We want to go ahead and call our meeting to order, and we appreciate everyone being here on today. I'm going to ask Dr. Martin if he would begin by reading the mission statement.
The mission is to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice.
Conflict of interest policy is an opportunity for each member to disclose potential conflicts and their belief that they can be unbiased and able to participate, or that they elect to recuse themselves from the matter. At this time, we will give opportunity for public comment if there's any.
If I could, Mr. Chair, on the conflicts, my law firm represents one of the entities whose contracts is before the board this morning. It's Epic's Healthcare. And so I will be abstaining from any discussion or vote on the Epic's Healthcare contract.
Thank you. Duly noted. Public comment?
No, sir.
Okay. I was on the elevator coming up, and I heard that they had a pumpkin decorating competition. So this particular pumpkin that I rode up on the elevator with, I invited to our meeting today. So,
Can he vote?
No, he cannot vote.
But it constitutes a quorum.
Right. So thank you. Also, as before we go get into our approving our minutes, I want to take this opportunity to welcome two new board members, one that joined us on last week, and I was absent, so I didn't have a chance to officially welcome Dr. Nettles and say thank you for being a part and lending your expertise and all of the things that you are familiar with to this board. So on behalf of the chair, I want to welcome you to this team. Thank you. And Attorney David, we had a chance to meet in one of our committee members. Meetings, you've jumped right in, and you have just been very brilliant in terms of the expertise that you bring to this table and bring to this space. And so we want to welcome you to the committee and give you an opportunity to say something at this time.
Well, thank you. I hope you don't regret asking an attorney to make a few remarks, because they're always longer than anticipated. But I'm so pleased to be asked to join the board and getting to know the organization, and certainly from what I know and have learned so far, such a long, rich history that the hospital has. And it's an honor and a pleasure to be part of this work, and really admire the hospital's work, and glad to be part of this board.
Thank you so much, and we're so glad to have you. Finally, I want to say thank you to this board for the trust to give me another opportunity to serve as chair. I think we had a great year, and I'm excited about the continued work we have to do. All right, you have the minutes in your packet. You've had a chance to review them. Are there any corrections, additions? Or if not, I'll entertain a motion to approve.
I do have one clarification.
Yes.
Where it is written for me, I am a retired professor of clinical pediatrics and a licensed psychologist, licensed clinical psychologist.
We will make that correction. Thank you. Any other corrections or additions that we need to address in our minutes? All right, I entertain a motion to adopt. Good second. Ready for the question? All in favor, vote by the sign of aye. Aye. All opposed? Ayes have. We've adopted our minutes. Under old business, we have a bylaws committee report. Dr. Martin, do you want to discuss that now, or should we roll that to a little further in the meeting? I mean, we can discuss it now if you want, or we can roll it.
I think we should wait until we have enough members to vote on it.
All right. So we'll come back to that. So let's go ahead and move forward with our new business. And the first thing under new business is the contracts. And we're going to ask our finance chair and any others that she deemed necessary to come and discuss the contracts with us that we have before us that they've reviewed. Smith, you recognize.
So the first contract we have on the agenda is the Edwards Pathologist Service Contract. Thank you, Dr. Brown. He spent quite a bit of time reviewing this contract, answering questions with us, and I will give a quick summary, but please, you have all the further details. I've had some conversation after the fact, and am interested to learn more about this opportunity. This specific contract deals with, it's a 3-year term starting January 6th, 2025 through January 5th, 2028. It is a new contract in which we would pay one individual who's the pathologist. The contract cost of $441,648. While there is language in the contract that refers to a group, it is one doctor. Right now, it is my understanding that we have one full-time, very tenured employee and a part-time associate as well. The hospital is looking to add a second pathologist. With this hire, they would expect the revenues to go up. And additionally, right now they have been outsourcing bills to and tests to Quest Diagnostics. And once we have Cerner up and running, they can bring these tests in-house, which will help create more revenue for the pathology department. And obviously, hopefully, to have this gentleman generate some revenue as well. We talked a little bit about the conversation with people who have been part of the PSA with Meharry, and the opportunity to continue that they've looked at other pathologists there and feel like this contract would be necessary to get the lab up and running and continue the good work. So if, Mark, if you have any other further comments around the contract.
I do not. I don't have any other comments to update unless other members on the board have questions.
Well, just so the rest of the board will hear this, I did bring up the question about the PSA and the fact that we do have two Meharry pathologists, but those two, I'm told, are really not able to handle the load. One is part-time and only wishes to work part-time, and one is very near retirement, and therefore that this person who is proposed is not a Meharry pathologist. There are no other Meharry pathologists apparently who do clinical pathology other than those two I mentioned. If what I said is incorrect, Dr. Webb or Mark, please correct me.
No, you're correct, Dr. Martin. So your question was if anything you said was incorrect?
Yeah, if I need to be corrected in what
No.
I just said
No.
about that relationship, please correct me.
Okay.
Thank you, Dr. Martin.
Go ahead.
Bruce, do you have?
I just have one question that our attorney reminded me. The total amount of this contract is actually 3 times the $441,648. It was correct on the finance committee, but it's $1,324,944 for the total contract cost. I just want to make sure we didn't flub it. It's right on the finance committee report. We just have a typo here. Yeah.
Okay, thanks, Bruce.
Okay, thank you for that correction. Is there any other questions? If not, I'll entertain a motion to approve.
Can I get a second?
Yeah, sorry.
Ready for the question? All in favor, vote by the sign of aye.
Aye.
All opposed? Ayes have it. Second contract.
Second contract is Epic's Anesthesia Service. This contract is, the term of the agreement is December 1st, 2024 to December 31st, 2026. This is technically a renewal and not a new contract or bidded. This is for our CRNA staff. We have a total of 6 CRNAs full-time here at NGH. They've been here quite a long time. This group had approached the hospital to raise the base pay for each nurse, some money, $10,000 for the medical director's position stipend, and $25,000 extra for the doctor. There will be a split back with professional anesthesia services for half the cost, and so this would just be an amendment to the contract that would allow us to be in range with other affiliate providers and keep our high-quality individuals here. So with that, Bruce, any other comments?
I think you covered it well. I'm happy to answer any questions, though.
This was, I guess, favorable approval from the committee.
Yes, sir.
Okay.
That's correct. And so I'll make a motion to approve the Epic's anesthesia contract.
Get a second?
Second.
Ready for the question? All in favor, vote by the sign of aye.
Aye.
Any opposed? Ayes have it. Thank you. Hospital utilization report. Ms. Poole, you recognize.
Good afternoon, everyone. I'm kind of combining the utilization report as well as the marketing report into one, if that is okay.
That's okay.
With the
Thank you.
board. Okay. Page 1, we have our utilization report for the month of October. I have left July, August, and September, so you can see the Q1 averages there, and you can see that we've had an increase in our October numbers for total hospital volume, as well as our total unique hospital volume. So the unique is the number of actual patients. The volume would be some patients may have come more than one time or for more than one service, which is a higher number. Our ED volume, we were pretty strong in July and August, dipped in September, and we have gone back up for the month of October. And then we do track our Metro employees who utilize the Metro Healthcare Incentive Program. And we had an uptick in Metro employees as well. It looks like they were here for about 1.5 visits during the month of October. So 405 unique Metro patients for 607 visits. And then our total ambulatory volume went back up from September, but stays in line with what we saw in October. Next, I just kind of want to share with the committee, this is what our FY24 heat map looks like for where our patients come from. We truly are a community hospital. We are not just in one section of Nashville. I think it's pretty shocking when some people realize Southeast Davidson County is our number 2 service market, and then up in Madison is actually number 3. So when we do talk about new hospital, why it can't be in just one corner of town, this is why, because our patients truly come from every corner of Davidson County. Also for FY 2024, we had over 100,000 unique patient visits or patient encounters, which was 34,000 unique patients and 1,800 Metro employees. To the right, our annual visits to the emergency room were over 22,000. Over 57,000 clinic visits and over 300,000 procedures took place. And that is everything from labs to radiology, physical therapy, and forensic blood draws as well. And then again, our payer mix might be a little slightly higher than 60%, but about 60% commercial insurance, 40% uninsured, which is flipped from where we were in 2015. Also, just demographics of our patients, and I apologize, the middle ones did not show up when we flipped it over here. So for our patients, the median age is 53. Employees were right around 47 and providers about 47 and a half, whereas according to the census.gov, the average Nashvillian is 34.6 years of age. So a very young crowd we have here. We're about 52% female, 48% male with patients. For employees, closer to 73% female, 27% male. And providers are 56% male to 44% female. And then 50% black, 26% white, and 24% other. For patients, employees, we're at 52, 40, and 10 respectively. Whereas in Nashville, it's flipped the other way, 27% black, 59% white, and 14% other. Yes.
Let me ask a question about that slide. For the payer mix slide for commercial insurance, says TennCare represents about a third of that. Can you describe what the other 2/3 are? And then also when it says TennCare, so why you characterize that as a commercial as opposed to a government payer, sort of Medicaid, Medicare, and then commercial being separate, just sort of some more information about the payer mix.
So for when we usually present, there are some slides where we do break that out a little bit more. And when we're doing annual reports or things like that, we just lump commercial with Medicare, Medicaid, TennCare. TennCare is a bulk of our what we consider commercial side or insured side, as well as your regular commercial insurance. And I'm going to throw Bruce out there, Dr. Blackledge. Oh.
I'll just say, Mr. Esquivel, TennCare used to be state, federal, and then when they started turning that out to United and the other third-party MCOs, most hospitals actually do treat it as an insured population, even though it may not be a great payer, because your claims are going to United and Centene and Blue Cross, just like they do for your commercial population. And so you create the risk of error. And so I'll just say it's not a game. Nobody's trying to mislead anyone. TennCare is an insured population. It's always been an insured population, but now they thread it through their managed care organizations. There's very little that actually still rests with TennCare, the state. It's all been farmed out to the MCOs in the state. So I know that's a technical explanation, but Dr. Blackledge has to bill Blue Cross, United, whether it's commercial or TennCare under those platforms. So that's why we capture it that way.
Let me give a little further explanation on that. TennCare is a waiver program, so it's not necessarily the equivalent of the traditional state-run programs. It's a block grant, so it's farmed out to the MCOs, which are the commercial insurance carriers. So all of those patients that come through that are managed by those MCOs, and that's to Bruce's point.
Great, thank you. One brief follow-up. So the remaining 2/3 that's within the commercial bucket, what do those comprise? I assume Medicare is a slice of that, and then others. Do you have any general idea?
Metro and Centurion.
Okay.
That's the bulk of
Yeah.
The bulk of it.
The bulk.
Great. Thank you.
Kathy, I can't read all of those details from here, especially the light blue ones, but could
Yeah.
you, have you circulated this? I don't think we've received.
No, I'm sorry.
Could you
I
do that?
I actually have them right here.
Oh,
I
okay.
passed those out so you can
Thank you.
read those. Thank you. So we're working on our FY24 impact report. So you'll see this information as we get that finalized by the end of the year. and we will be on slide 5. So back in 2015, this is kind of who we were. We were Nashville General Hospital. We had our School of Health Sciences. We had our Nashville General Hospital Foundation, which was actually called Friends in General back then. And then we have the Our Kids Center, which was founded by Nashville General, Vanderbilt, and the Junior League of Nashville. So fast forward to 2024, next slide. And this is what we look like today. So in 10 years, we have rebranded our clinics under the Nashville Healthcare Center name. We have the main campus, Midtown Metro Center in Bordeaux. And then we added a weekend-only urgent care at the Bordeaux location. Metro Center also houses a new rehab therapies section there. We have our community pharmacy at Nashville General that opened up. It's on the first floor. We want to ensure patients have access to their medications before they leave the hospital. And then we have also become a 340B, Dispensary of Hope location ourselves in St. Thomas, so patients can get the medication they need at a drastically reduced rate, if not free. Then 2019, we opened up the food pharmacy at NGH. Again, that is based on your disease diagnosis. It is not a food pantry. Patients, you have to be a patient of Nashville General. And we started with our cancer patients. Now it is including our hypertensive, diabetic patients. They're referred down there. They get 2 food bags, which lasts them 2 weeks. And then they come back to help with their disease state and improve their outcomes. Congregational Health and Education Network was also launched. That is our collaboration with over 100 churches in Nashville. We do a lot of community outreach, so there's a lot of coordination between my team, the ambulatory team, as well as our CHEN team, so that we go out and do health fairs. We provide churches with an overview of this is what your health outcomes look like for certain events, so that we know how to target and bring services to them to help better their health outcomes. We also launched this year the NGH No ADR, strategically to help improve patient throughput through our emergency room, innovated the triage process. So your average wait time door to bed is 4 minutes, door to the provider is about 7 minutes. So that, obviously there's going to be a longer wait time based on tests you need and other things going on in the emergency room, but that's where we're really trying to drive and improve care for the community there as well. Next, we have our Middle Tennessee Health Partners. This is our strategic approach that goes business to business, not just business to consumer, targeting employers, insurers, and other healthcare networks. Using this physician hospital organization, PHO, helps strengthen partnerships and align goals and streamline our service delivery. The Middle Tennessee Health Partners is tailored for Metro and Davidson County, leverages evidence-based population health to improve outcomes and expand access. This enhances our marketability, where we're focusing on not just recruiting, but building our referral networks and demonstrating value-based care to improve outcomes and manage costs. Next, we have our Nashville Healthcare Center Bordeaux Weekend Urgent Care. It did open as a weekend-only urgent care in what is considered a healthcare desert there in Bordeaux. So the community convenience to have access to medical care outside of weekday hours and addressing immediate non-emergency needs when many primary care offices are closed. And then we opened up our Nashville Healthcare Diagnostic Imaging Center. The standalone imaging center, again, located in Bordeaux, a healthcare desert, benefits both the community as well as our healthcare system. Focuses on improving access to essential imaging services like x-rays, MRIs, mammograms. They have an ultrasound machine, and filling a significant service gap so patients don't have to travel all the way into Midtown or north to other facilities to receive care. And it just helps embed us to doing our community-based approach to healthcare. And then Nashville Healthcare Pharmacy just opened. It is an outpatient pharmacy in our Nashville Healthcare Metro Center location. This is our busiest multi-specialty practice. Again, patient convenience and the continuity of care, providing on-site same-day access to prescriptions. We've been a little busy. And then last but not least, we do have, don't forget, I know last month my team had little things on the tables to encourage y'all to please scan, follow us on social media. Our things are more event-based. Dr. Webb has more thought leadership and other things on his social media sites. Any questions?
Going back to the who we touch slide,
Yes.
the 1,800 Metro employees, do you know if that's up, down, or flat compared to last year?
It is up,
Okay.
but we're still hovering about 5%. But when I drill down to our ambulatory site, it's almost 20%.
Okay.
So we are looking at where they're coming and trying to pinpoint other areas. We will also be adding NES because we have that incentive program, and the state incentive program will be launching in December because their insurance changes over January. So we'll add that as well.
Thank you.
Yes, sir.
Congratulations on all of the initiatives and the marketing of those initiatives. I just have a question about the identification with Nashville General Hospital. Some of these that are listed here say Nashville Health Care Center. We know it's associated with Nashville General Hospital,
Correct.
but how does somebody else know that?
That is our double-edged sword. If some people hear Nashville General, they're not coming. Truly. So we launched Nashville Healthcare Center as a separation. It started as one of our primary care clinics for the Metro employees back in 2015, 2016. When Dr. Webb first arrived, the one thing we heard consistently is Metro employees did not want to be in the same doctor's office or clinic as everybody else. So our internal medicine clinic, you were waiting long wait times. It's a teaching clinic. They wanted that traditional doctor's office. So that's where Nashville Healthcare Center came from. And then a few years later, we just started pulling all the ambulatory brands when we opened up our first location in Midtown and branded it Nashville Healthcare Center. So that's kind of, we've stayed with that as we've expanded other service lines, even from getting websites and things like that. Like NHDI's website is actually NashvilleImaging.com. So really trying to figure out what works, where people, what they want to hear, what they want to use. I'd take Nashville Health if I could, but that's already been taken.
So really the bigger issue is marketing Nashville General Hospital to everyone in a way that's acceptable.
Yes.
That they all want to come here or be associated with some element of Nashville General
Yes.
Hospital. So that's a bigger marketing issue
Much bigger.
that we will not resolve right now.
No, but it is on the, we know it's there that we have to address. Even our, we'll be launching a new website coming in. We just kind of redesigned it a bit so that all of the entities go to Nashville General Hospital because we know that's our top brand.
Any other questions? Thank you for this report.
Thank you.
We will now have the quality report. Denson, you're recognized. Yeah, oh, I apologize. You're absolutely right. Foundation report is next on the agenda. Foundation is important, and I apologize. Thank you, Mr. Lester.
Good evening. I'm going to give a quick update of the foundation. We have 2 staffing updates you can see up there. We have hired a volunteer coordinator. So in the past, oh my gosh, has it been 8 years? Kate Haygood has been wearing 2 hats of annual giving manager as well as a volunteer coordinator. So we have split out that position because we know that volunteerism is very important to a hospital and especially for Nashville General. So really, really happy to have Alex on board, and she's going to bring some really great insight. You can see her background, 10 plus years in mental health and addiction services. She has a lot of wonderful contacts in this community, so she's a great addition. Next slide. So I'm going to switch gears and talk a little bit about our leadership campaign. Last time we all met, I discussed a little bit about the board, meaning the hospital board, as well as the foundation board, kind of leading the annual campaign for the foundation. And so I just wanted to give you a quick update. We've had 19% in response, and the campaign actually ends today. So I just want to point out that materials for this campaign are in your package. It's not too late. It's never too late. And it doesn't mean you have to give by today. You can at least pledge today. So if you need to go over today, that's fine. But really, it's very important that the giving starts at this level. A lot of grants, a lot of donors will ask me, do you have 100% giving from your boards? Right now, I can't say that. So if you have any questions, my contact information is in the packets on your table this evening. Next slide. So campaign study.
Jen?
Oh, yes, I'm sorry.
Is it possible that some of the board members have contributed but maybe aren't identified as board members?
So I feel like we've done a really good job with our CRM system. So we have all of our hospital board members in as well as our foundation board members, and I have pulled reports, and we're still at 19%. So.
Just a quick question with the leadership campaign. 19%, is that this board and your board?
No, it's just the hospital board right now. The foundation board is at 50% right now.
50. And remind me how many people you have on that board?
We have 12.
12. Thank you.
Jen, if I could just add that this is what Jen said about asking for foundation money or grant money. It is absolutely critical to have 100% support from the board. That doesn't mean board members have to give their life savings. Something, so that Jen can say that every member of this board has made a contribution would go so far in helping Jen generate more opportunities through foundations, grants, and other requests. So I would just urge all of us who have not committed to please pledge something. It doesn't have to be a large amount, although it would be great if you would. But any amount will do to make sure that Jen can say 100% of the board is on board. Thank you.
I just want to say I concur. I sit on the foundation board for the Predators, and I review grants, and that's one of the questions that we do ask, and so I know that's important, so thank you for pointing that out. you can continue.
Any other questions?
It's really not a question, but a comment as such. When you're really brand new and you didn't know that you're supposed to, and so it would help a little bit if that was part of the orientation in order to make sure that you can plan in order to be very efficient and see what the needs are.
Great.
So, I will say that is applicable to me, but I was just taken.
It's a great feedback. Great feedback. Thank you. Thank you very much. Okay. Just moving on to the campaign study. I know we spoke last time about launching this study to look at the feasibility of having some type of capital campaign for a new hospital. And so many of you have partaken in the interview process. So there were two different ways to participate. You can interview, which was a Zoom interview, or there was a survey sent out. So I want to thank you all. We had really, really good participation in this. So basically the things that we were looking at is we wanted to see if the community and our donors are ready for a campaign, and also look at possible goals or possible leadership that could come out of these conversations. And so the final report will be presented at the next board meeting. So we are working with a organization called Pride Philanthropy. They've been around for 40 some odd years. They're based out of Georgia. And they're just experts at this. So initial findings. So I have been asked a few questions about what do we know so far. So I have just gotten a little glimpses, and it's just hot off the press today. And these are basically just from initial surveys and a few of the interviews, because the interview process is still going on till November 8th. So just a couple of key things. There's been statements about a need for better branding and visibility of the hospital and foundation in general. And then another one that was identified was a weakness, and the community knows the need for a new hospital. They know there's a need for better infrastructure for this hospital. You know the condition right now. So there's two key takeaways. But I really found this quite inspiring. The top reasons to support the organization, because we address healthcare disparities. We have a long, rich history in this community, and there is quality care here. And I think we should all be really proud of that for all the people that we interviewed. They heard it time and time and time again. So please come to the November 21st meeting. We will also have the foundation board here as well to hear those results. Next slide. I'm going to go through these really quick because I want to make sure I don't go over time. But I just wanted to show everyone really quick how we're doing. The yellow right now is the current year versus the orange, which is prior year, and the red was 2 years ago. And the reason why I wanted to show you this slide is because I've been here 8 months. We're seeing some nice growth, but we have a ways to go. And then you can see at the bottom the category of active donors. There's all different categories of donors, new, attrition. Attrition, we are not there yet. We have lost donors. So a lot of stewardship, a lot of visibility, creating the message that inspires people to get involved. Next slide. And then dollars raised year over year. We're not doing too bad. We're actually doing really well. We're trending a little ahead of the game this point compared to last year. So we're doing fairly well. Next slide. And then these little dots here, I like talking about losing donors because it's really, really important for foundations. It costs you, twice as much to get a new donor than to retain a donor. And that loyalty is really huge for foundations and for revenue growth. So we're doing okay. We're getting better. We're getting closer and closer. And we're just behind the national average. So we've got some room to grow that, and we do have a very robust stewardship plan to make that happen. Next slide. Just some quick updates. With our annual giving program, you may have seen we have some recent campaigns. We have the all-weather wellness campaign. And upcoming campaigns is our Food is Medicine that will support the food pharmacy. And then many of you may probably have seen a lot about the breast cancer awareness. And we have Judith's story. She was a former employee here for volunteerism. And so she has an amazing survivor story. Next slide. We did finish up our employee campaign at the end of September. We had various engaging events. You can see all the events that we had. We learned that a lot of the employees have a lot of talent here, very talented people. We raised $30,000 from 87 donors. While that is not fabulous, I will tell you total dollars raised. Last time the campaign was done, I think 3 or 4 years ago, we remained flat. So we have some key learnings, and at least we didn't go down. So we're looking to build upon that. So every year this will be a campaign. Next slide. And then just some of the community outreach on some of our social media about getting the new patient courtesy cart. Just in 3 weeks, we have transported 311 patients from the parking garage to the hospital. So it is getting well used. Next slide. And then, of course, we had our sprinkles of gratitude for our volunteers. We had volunteers come, and we had a really nice time. And so we also had our Elevate newsletter. I also sent it out to all of you as well. This will be on a quarterly basis, and we're trying to raise the visibility and the branding of what the foundation does. Next slide. So that's it. Any questions? I did have a couple other things that you're on the table next to you. I have the International Women's Day breakfast that will be happening on March 4th. So all the information about that event is there. And some of you have gotten back to me about writing thank you notes. This is a season of giving, and so we are writing notes to our volunteers. If you don't have a packet of notes, please let me know. I have a bunch of them over under my chair. Thank you.
Thank you. Great work.
Excuse me, Jen,
Oh, we got a question.
do you have a list of people that we can write?
Do you not have your list in there?
Oh, I see it. Okay. Thank you. Yeah.
Thank you. All right, now we'll get to our quality report.
Under our safety of care goal 1 metric, we have continued to see no falls with injuries, so we continue to be more than 365 days without a fall with a serious injury, so no action plan is required there, and we're continuing with our current state with our bundle. For hand hygiene, we did not meet our goal overall, but we did see a significant increase from 84% to 94% month over month. And we're noticing that now that we've increased the number of observations across our departments, that we're continuing to see that trend go upward. So hopefully when we do our October data, we'll see those numbers go up as well. Under barcode medication administration, this is our metric around ensuring safe medication distribution at the hospital. We're meeting that goal at 97% too as well. Under goal 2, quality of care, this includes our hospital-acquired infections. And since last month, we have not had any healthcare-acquired infections. And I wanted to give a general overview so that you all will know how long we've gone without any of these particular healthcare-acquired infections. For catheter-associated urinary tract infections, we've gone 365 days without a single infection. For central line-associated bloodstream infections, we've gone 209 days without an infection. For MRSA blood infections, we've gone 424 days without an event. For C. diff infections, we've gone 429 days. Surgical site infections involving colorectal cases, 344 days. Surgical site infections involving abdominal hysterectomy cases, 423 days. And for surgical site infections involving C-sections, we've gone 104 days. So great outcomes we're seeing associated with those particular metrics. Goal 3 is around timely and effective care. And unfortunately, we don't have any updates for this month. We're experiencing a little bit of a data lag in getting our laboratory results for this metric. So next month, I'll have some updates for you all for that one. Under patient-centered goal, this is our patient experience metrics that we get back from our patient satisfaction surveys. We are meeting our goal for responsiveness. We're at 83.3%, and that has increased from 58.3% last month. So we were very happy to see that metric move, and we think a lot of the work that we put in place with our nursing partners and being more close to the patient rooms, being able to respond to those call lights have really helped, and we've done some significant improvements in making sure that our call light system is working effectively. Under cleanliness and quietness, we are at goal for the second consecutive month at 90%, so it was great to see that metric move as well with our EVS partners. Under willingness to recommend, we're not meeting that goal at 90% with a benchmark of 74. And I wanted to go into some of the things we're putting into place as an organization to address these. Our patient experience team is working collaboratively directly with our physician and nursing leaders to address some of the specific comments that we're getting back on those patient experience scores. And we're noticing that a lot of that score is coming into play because of our environment, where a lot of our patients are commenting that the building looks dated and old. So we're addressing that in some of our commonly used areas like our waiting areas where we know that our patients and visitors congregate, to try to do a refresh of some of those areas to address those concerns, because a lot of those scores did come back from our surgical patients. We are increasing hourly rounding as well so that we can tend to some of the observations and coaching staff as well in responding to patients' concerns about any type of environmental needs in their room that we can control. Also, too, all new admissions continue to be rounded on by patient experience. So we do have 2 individuals amongst that team that do go and see all of our new admits to greet them, but also thank them for coming to Nashville General Hospital, as well as addressing any concerns proactively. Also, our executive leadership team continues to round to support this goal, to be a presence with our patients. And also, we're focused on being more directly involved in making the hospital experience a little bit more personalized to our patients and sharing access to our portals and other materials that's out there on our website. Under Goal 5, Culture of Safety Survey Response Rate, in your packets, we did not include the response rate because we got it after the submission deadline. But this year, we had a 65% response rate, which is nothing to be disappointed about. We didn't meet our goal of 75%, but we are digging a little bit deeper into those responses. And at the next board meeting, I will have a summary of what our staff members are saying around their engagement with the organization, and as well as their thoughts on how safe the organization is. One of the things our team is being committed to is making sure that we're promoting these outcomes that we're seeing with our patients, because like I shared last meeting, these outcomes are not the typical outcomes you see at a lot of acute care hospitals, so we should be very proud of these. But we're not always doing the best job in making sure our staff members know about these outcomes so they can see that we are providing high quality, safe care to our patients. Under Goal 6, our regulatory goal, we did not meet our goal for the EMTALA audits from that survey that we had back in June of 2023. And that was due to just one patient that fell out. And we're hoping with the Cerner implementation that a lot of the documentation concerns that are centered around this metric, that we'll have those alerts to trigger our staff to make sure that they're documenting those key data points. We did have a visit from the Tennessee Department of Health earlier this month that was related to 9 patient complaints. And these complaints go back from January 2023 all the way to August of this year. But after a very aggressive 2-day survey with 2 surveyors, they did deem that no findings were noted and none of these complaints were substantiated. So we were really pleased to see that outcome from the survey. We are in our Joint Commission survey window. We should anticipate them hopefully by the end of November. So by the December board meeting, we'll be able to give an update on how we did with that survey as well. And one thing that's not in your packet, I know that a lot of you have probably seen in the news, the IV solution supply disruption. And I'm proud to say that through some very concerted interventions here at Nashville General, we were not impacted by it from a patient care standpoint. We put our pharmacy partners, our executive team, nursing, physician leaders, myself, many of us came together to review a lot of the standards that were out there and recommendations on how we could be better stewards of this resource. And luckily, we were able to maintain our 96-hour stockpile every single day, and we continue to do there. So no patients were impacted by that disruption. Any questions? All right, thank you.
I have a quick question.
Yes.
And we may have talked about this before, but is there an annual employee survey that's done?
Yes, that's the employee engagement survey that I was mentioning. We got the results back, I think about a month or two ago, but I just received the report with the summary of where our primary key drivers are, where we're doing well, and some things that we need to address as an organization too. At the next meeting, I'll have an update to share.
Okay. If you could get a summary to us, I think that would be nice for us to be able to read and be able to have that visibility as well. And then, again, you guys may have told me before, but why is there a 3-month lag on a lot of this data?
It's because a lot of this data is dependent upon our reference lab results, and those results do not automatically transfer over to the medical record electronically. They're scanned in, and so we have to wait for those scans to get uploaded so that we can have access to the final record. We do have the ability to see some of the preliminaries that come in, but sometimes they might be modified, so we do rate for the final scan.
And that's not something we can control, correct?
No. When Cerner goes live, these data transmissions will be a lot more concurrent. It's just right now with the volume of labs that we're doing off campus, it's a little bit more difficult to be able to get those scans in fast.
Thank you.
You're welcome. Any other questions?
Do we have a new go-live date?
For Cerner,
Yeah.
December the 16th is our magic date.
Let's be during JCO maybe too.
No, it won't be. Our Joint Commission consultant assured us, and they're aware of our Cerner Go Live, and we actually gave them a 3 to 4 week time period. They don't have to honor it, but our consultant told us that they will honor it. So no, they will not be here during that time period. Great question, though. Thank you.
Wait a minute. You will need to approve your report.
Okay, thank you.
So I'll entertain a motion to approve the quality report.
So moved.
Second.
Been moved and properly second. Ready for the question. All in favor, vote by the sign of aye. All opposed? Thank you, and thank you for your report.
Thank you.
All right, so I want to go back to old business, and we really need to review and approve our report from the Bylaws Committee. And so at this time, Dr. Martin, Committee Chair, you're recognized for information on the Bylaws Committee report.
So before you is a copy of the most recent version with changes, and I will refer to some page numbers. We're going over this because although we did this last month, there were 2 problems discovered that are not clearly spelled out in our bylaws, so we didn't know about them. One is a requirement that the bylaws be circulated 10 days prior by certified mail or some other, proof of that this is done. And in our bylaws, it just says that they be circulated according to a state rule, which is not spelled out. And the other is that it requires 2/3 of current board members. My interpretation of 2/3 was 2/3 of people who are in seats as board members. This has been clarified by legal just tonight that we're supposed to count all 11 seats. So that means 8 votes instead of 7 votes. Yes, sir.
The clarification is because the current position, it was appointed and there was a resignation, which therefore means there was a termed member in that 11th seat. If that term had expired and there had not been a duly appointed person, that wouldn't count. So that's what the state statute that I went through an analysis on. So there's a distinction. You could end up with an expired term position that had never been filled, and therefore you could have the lesser number. But because Dr. Birch resigned from a duly appointment as a member, it changes the analysis. So that's why I gave the opinion that it would require a vote of 8 as opposed to 7.
Okay. Whatever. Anyway, we do need 8 votes to change the bylaws. Members of the board have been working on this for 2 years, and the previous team who put most of this together is no longer on the board. So I'm hopeful. I appreciate that everybody that is here, and I'm hopeful we can get through this tonight. We went through this in detail a month ago. I'm going to go through it at a little bit of a more highlight level for time's sake, and because most everybody's heard it all. But also the bylaws committee met again between the meetings and made some other changes, most of which were suggested by the board at the last meeting. So you will have heard them. So I want to start on page 4 at the top, and everybody has heard this. This is not changed, that one of the board members shall have special training and practice experience in the field of psychiatric medicine or psychology. I don't think that's controversial. We've talked about that, and we voted to approve it last time. If you go to page 5, under closed session, there's something that's been added to the first sentence. Tennessee law authorizes the board or a board committee to convene an executive session closed to the public in 2 instances, and these instances are the same. A third instance is actually mentioned at the bottom, but this is not a change with practice. What's new in here is to clarify that a board committee can convene an executive session, and that will come into play when we get into discussion of the committees. If you go to the next page, page 6, and we discussed this before. Last month, hasn't changed. Removal of office. We've had a lot of trouble getting business done, particularly this summer when we had 2 meetings canceled for lack of quorum. The wording here is the same as we talked about, I'll just point out once more that this is not retroactive. This is talking about in the future. Any questions about that? This is just an attempt to encourage people to be here so we can get our business done. Also on that page, under Article 4, Officers of the Board of Trustees, we put in something here that says elections for officers will be scheduled for the June board meeting each year. That's just to get us on a regular schedule for election of officers. And somebody pointed out that, well, what if the June meeting gets canceled? So we're going to schedule it for the June meeting. And if we don't have enough people, then that's another vote that requires a majority, not of the members present, but a majority of all the members of the board. So quorum's important. So at least we'll do the work, have the nominations ready. If we can't do it in June, we'll do it the next month. On the next page 7, there was some discussion about changes in the medical staff credential committee and the compliance committee. First of all, just to deal with the compliance committee, both in the last board meeting and in the bylaws committee, there was a desire to keep the compliance committee. One of the concerns was about discussing certain compliance issues in public meetings, but our council assured us that the compliance committee itself could have closed session meetings. In fact, one difference is a closed session compliance committee meeting can be called and scheduled, unlike a full board closed meeting has to be voted on in an existing hospital board session. So again, we think that this accomplishes this goal and allows us to discuss sensitive issues in a compliance committee. The suggestion was also made that we eliminate the medical staff committee and instead have essentially a medical staff liaison, which we all thought that this was a very good idea. So if you look on page 9, it says special medical staff oversight appointment. The board would appoint one of its members to represent it in the oversight of medical staff as follows. And the A through G there are unchanged from what the compliance committee was going to do. And the idea is that there's basically a board member that's medical staff liaison who will participate in some of the medical staff committee meetings and be able to know what medical staff issues are, and also ask questions before the board meetings about any questions about credentialing, so that when we get a credentialing report, we have one board member who's already familiar with all the details of that. Take you next to page 11, contracting matters. What you see here is what we, these have been in these proposed bylaws changes for over a year. Part of it was to streamline board meetings so that we have had, because of something that was adopted in the minutes years ago, we've been seeing every contract that was over $50,000. This proposes raising it to $100,000 to take some of those smaller contracts out. The other thing that was put in here was a limit over which the board had to see professional medical services contracts over $375,000. Still not quite sure where that proposal came from, but Dr. Webb has expressed that this will make it recruiting hard if they have to wait for a month for the board to meet when they're trying to recruit somebody that we really need. And also, we don't necessarily need to be discussing physician salaries, all physician salaries in open board meeting. So we have an alternative wording for that. I'll pass around and we should discuss it, and I'll be asking for a motion if anybody thinks that this is a good idea. Basically, to just remove the requirement for medical service contracts to be reviewed by the board at all. And Stacy, in addition to what you see there, has proposed adding the words in A there, the CEO is delegated the authority to enter into any new contract for professional and medical services, and then these extra words that are not on your sheet of paper, or employment arrangement. Stacy, would you care to comment on that? That's, is Stacy here?
Yes.
Yeah.
I am here.
There you are. You're behind me. Okay, thank you.
Sorry for...
Find a microphone, please. You go to the podium.
That's just a simple addition, because the notion behind that is that the CEO would have the flexibility to hire and do employment, to employ people as needed in the hospital. And so, as we noted there, that he's delegated the authority to do professional medical services agreement. It was brought to my attention that there are also other contracts that happen in an employment context, and generally in an employment agreements don't come before. You want your CEO to have the ability to hire as necessary, separate and apart from other contracts.
Thank you, Stacy, and for all the work that you have done on this arduous process. I personally am in favor of removing that and adding those words. But anyway, that's the report of the committee and the recommended changes. There are some other changes that we discussed before and have been circulated to you and even mailed to your home. If there are any questions, I'll be glad to answer them. Otherwise, I'll turn it back to the chair to consider this amendment and the bylaws changes as a whole.
I have a quick question. The question I have is really to understand the terminology around what professional medical services means. And I just want to make sure I'm clear on that. And then the other thing would be, is there some language that would be fitting that would be, instead of just having deemed reasonable and necessary, does it make sense to put in some language that would be appropriate to the position with regard to, let's say, a standard or an average or something like that within a plus or minus? I guess I'm just trying to say, putting in some parameters, not trying to tie, we don't need to micromanage the process, but some parameters that would be commensurate with that type of position. So a full-time, like we talked about the pathologist. If I'm paying a full-time pathologist $441,000 as an example, and we go hire someone who we're potentially paying $700,000. I guess I'm just trying to think from a liability standpoint and creating language that helps us stay within certain parameters. So again, I'm not in that field specifically, but I'm just thinking from a legal perspective, is there some language that we would need to add that gives us some coverage?
Well,
thank you.
To me, professional medical services is our providers and also our respiratory therapists and, anybody who's providing medical service, doctors, nurse practitioners. I may be wrong about that, but that's my impression of that. And, I've asked Dr. Webb the same question about, maybe the number's too low, and maybe, I kind of challenged him with a ridiculous thing of, if he wanted to hire somebody for $4 million or something like that. I think it's a legitimate discussion that we should have, and I'd welcome your comments about that. Okay.
Yeah, I hear what you're saying, Christy, but I think overall the point of this is to allow the CEO of the hospital to make the operational decisions that he seems fit. And so I don't know that we want to creep back into putting some kind of a surround around that unless there is a real legal need for that. It seems to me that the wording that's here allows Dr. Webb to do what he is asked to do as CEO. And if we have a problem with that, that's another issue. But in going through the day-to-day practices, I think this revision that you have come up with really responds to the concern that Dr. Webb had about the professional services and exposing those salaries publicly and the recruitment issue associated with it.
Yeah, when we were in the committee meeting, I was kicking myself that we missed this because, you know, we went through it, but we just really missed it. And I started thinking about how it really handicap us in terms of being competitive. You know, if I'm a physician and I've got a couple of offers and you tell me I'll get back with you, you know, in 30 days after my board meet, you know, if I've got some other opportunities, I'm not going to wait for that. And so we would be putting ourselves, you know, in the second place situation in terms of recruiting top-notch staff. I also think that when it comes to recruiting and paying fair market value, you know, the parameters that we shouldn't put those parameters here. We should put those parameters on the expectations from the CEO. And so not necessarily in the bylaws, but in terms of what we expect. And so I was concerned, I'm probably more concerned that we went through this pretty thoroughly, and I was kicking myself that I missed it, because I normally would catch something like this. So I agree with the language that of this amendment, if we could possibly just kind of add what we have here.
Again, I'm not trying to say that we are by in any way, shape, or form disclosing a specific name with a specific salary. So I don't think that that's appropriate at all. So let me be crystal clear on that comment. What I am saying, though, is just a function of language saying, again, not trying to slow down the process either. So, again, crystal clarity on that. What I'm just saying is, does it, from covering our own back end, make sense to, from a legal perspective, add some language that specifically is in line with fair market value, to use your verbiage specifically. So, again, I'm not trying to handicap. I'm not trying to micromanage. More than anything, I'm just trying, from a legal perspective, to be thoughtful that there's language that the appropriateness of that, and none of that has to do with not offering a contract. None of that has to do with disclosing names. So I'm just asking from a legal perspective.
If I can ask, what would happen? What would be the process? Let's say Dr. Webb wanted to hire an ophthalmologist, and he offered $3.5 million a year, which is obviously well above MGMA. What would happen? Would that happen without us knowing about it as a board? What would that process be? And I ask that because it seems obvious that if there were something that were way out of line, that we would know about that and it would raise some flags. But I guess I share other sentiment that I think we entrust the CEO to run a hospital, and I'd also reference, do other hospitals put on parameters as far as who they hire and as far as talent? I think you end up hamstringing yourself if that's the case. If you're not competitive from a pay standpoint, you're not going to get high quality doctors. You're not going to get high quality surgeons. It's just that's in my experience in 12 or 14 years of being in this community. I don't think that's the case.
So let me answer the second part of your question. Is I did do some investigation, and there's no precedent for a board of a hospital to get involved in recruiting and setting salaries for doctors. As far as what would happen with a $4 million ophthalmologist, I'll let Dr. Webb answer.
No, you should probably terminate me if I did that. I've been here 10 years now, and we've recruited physicians. We use clear standards to make sure that we don't go beyond the median. Now, if there's some outstanding reason why we would need to, I don't think the board necessarily would need to step in and turn that around. There would have to be a very good reason for the hospital to continue to perform its services for that to happen. So I don't think this is an issue. It seems like a problem. I mean, a solution that's looking for a problem, which doesn't exist.
If I could speak, Chris, to your question about legal, and it's not legal advice, but just thinking about the wording, and if I understand what your concern was about the phrase at the end that says in such amounts as he deems reasonable and necessary, whether that defines some limit. I'm not sure that's necessary. If the sentiment of the board is that these decisions are entrusted to the CEO, including setting the amount of salary, negotiating these, that it's advantageous, do we need to say anything about reasonable and necessary? Do we accomplish the same purpose by saying the CEO has delegated the authority and to enter into any new contract for professional medical services, period? And that way we're not going into the realm of what, empowering the CEO to, or holding the CEO accountable to something through the bylaws. That I'm not sure. What I'm hearing is that it's be odd for at the board level to have this amount of detail. And so I don't know. I asked that as a question, is whether that's the kind of thing you meant by legal, cleaning it up legally. When I read this, I don't see a need for the last phrase at all. It can just end with and authorizing the CEO to enter into these contracts. As an addendum, I would say it says the other thing, that if we do keep that language, the bylaws generally seem to be good at using gender-inclusive language. And so I think if we leave that language in, I think the word he could be modified in the event that the CEO is not a he at some point, and because it's in keeping with, I think, good gender-inclusive language in the rest of the bylaws.
I actually would have that. I had that same concern. Why is it necessary to add that last phrase? If the CEO is making bad decisions, then the board needs to deal with the CEO for that particular purpose. And so I could say that over the 10-year period that I've been here, I don't think we've made such decisions. So there's no evidence that there's a reason to be concerned about that. I would wonder why that would be inserted.
While she's coming up to speak, if the salary is $3.5 million a year, Brian's going back to school to get his ophthalmology license.
Okay, so we haven't adopted this amendment yet, so I agree. I think if everybody's okay, you can just nod your head that we can take that part out. And so, in such amounts as he deems reasonable and necessary. So we just scratch through that, and the rest of it will be included when we get to the amendment. So I agree. And our attorney agrees as well.
And just to be sure, Stacy, the addition of or employment arrangement, does that need to be in there?
No.
Okay. So basically, the suggestion would be, and we would entertain a motion for amendment to strike all of the red in there and end the sentence with a period after the CEO has delegated the authority to enter into any new contract for professional medical services, period. And then all the red goes away.
Are you making that amendment?
I think somebody else would have to make that amendment because I'm representing what
All right, well, I'll make that amendment.
Okay. Okay, so I'm sorry, we haven't done anything yet.
Completion of the report from the committee.
Yes.
Where you begin to, okay, if it's at the end of the report.
That's the end of the report, yeah. Thank you.
All right, so what we'll need to do first is, I think, approve the report and the minute and the recommendation, the bylaw change recommendation, and also to approve the amendment.
What I was going to suggest is don't vote on accepting the recommendation without first entertaining the motion to amend. That's what I would recommend.
Okay, we can do that first.
I second the motion to amend.
All right, it's been moving properly second to include this amendment. All in favor, vote by the sign of aye.
Aye.
All opposed? All right, ayes have it. The amendment has been adopted. All right, we are now on the approval of the bylaws. Janet, we don't need a roll call vote, do we? Okay. All in favor of adopting the bylaws with the included amendment, vote by. I'm sorry, I do need a motion.
Well, the committee report is
what
the
we're
motion,
adopting.
Correct? It needs a second.
It's okay. We'll
Have a motion and a second.
just give us a motion.
Okay.
Go ahead and give us a motion.
So I move the adoption of this current version of the bylaws as presented with the amendment that just passed.
A second.
All right, now, we've been moving properly second. All in favor, vote by the side of aye.
Aye.
All opposed? It is unanimous. Thank you. And thank you, Buzz, for your hard work and detail into leaning in to get this thing done. All right. Medical staff reports. Let's go back to new business.
Good evening.
Good evening.
I want to make sure it wasn't missed, and I have two things to touch on, but a moment ago, Dr. Fisher suggested 3.5 was a reasonable salary for an ophthalmologist. Dr. Martin countered with 4. I'm the chief medical officer, but full disclosure, I'm also an ophthalmologist. I'll touch briefly on the bylaws. I do not have any specific updates to share at this time. These represent an ongoing effort. There will be updates down the road. Number 2, credentials. You have the list in front of you, and I won't read it to you, but I will draw your attention to and highlight 3 service lines. That's anesthesia, emergency medicine, and behavioral health. So those are 3 service lines in which we now have just a little bit more robust of a team and a deeper bench. That is all I have. Are there any questions I can answer or anything I can speak to?
All right, we have the report in front of us, and we've had a chance to review it. We'll entertain a motion to adopt the October credentials report.
So moved.
Second.
All in favor, vote by the sign of aye. All opposed? Thank you. All right, our finance report. Ms. Smith and Bruce, you are recognized.
Good evening. Our August financial report, a good volume month in the hospital setting, good volume month in our clinics, busy emergency department, so I'll just walk through a few of them quickly. We had 254 inpatient admissions, which was about 15% above the budgeted threshold. We had 192 observation admissions, which was about 10% better than the budgeted number, and our patient days were right on that 15% difference in admissions to the positive. Our length of stay for the month was 3.9, which was right on the budgeted number and about 15 to 20% lower than where we ran last year. So credit to our utilization management, case management teams, and our physicians and hospitalists for moving patients through efficiently. As far as the emergency department, we had basically the same number of visits this month at 2461 as last month. That was about 5% higher than the budget. And compared to last year, it's about 8% year to date. We've had a nice increase in the emergency room volume first 2 months of this year. Emergency admissions, almost 200. The budget was 178. And then I mentioned the clinic visits, 4,831 visits in the month of August, about 1,000 more than our budgeted number. A lot of that is attributed to the Metro Center Clinic, where we have 2 full-timers and a nurse practitioner there, and they were not in the original budget. They do see about 800 patients a month in that clinic. As far as surgery, the numbers dropped just a little bit this month. They were really high last month, both inpatient and outpatient. Again, this month they were well above budget, 39 inpatient cases, budget was 27, and 111 outpatient cases, budget was 87. So we did really well in those two. Now, where we didn't do as well, numbers-wise, is the cath lab volume is dropped. I think you guys recall that our interventional cardiologist left employment at the end of May, and so we're close to having a replacement interventional cardiologist working on getting his credentials in place, financial credentials, so that we can move forward with that. And our cath lab has been under construction for a couple of months, and I think Mark and Dr. Webb told me it is ready to go as soon as the physician is ready to go for us. Deliveries, again, last year, a year ago, we had really high. We were in that 450 deliveries a year. And this year, for the last 12 months or so, we've been pretty low, mostly in the 23 to 25 deliveries per month. So that's sort of the basic stats for the month of August. And then I'll quickly move into the income statement. The inpatient revenues were about 15% above budget, which makes sense because our days were 15% above the budget. The outpatient revenue was about $2 million short of the budget, and most of that, a lot of that was the cath lab. Without having a practitioner in the cath lab, our outpatient revenue there was pretty low compared to what we had budgeted. Also, the observation days, even though the observation admits were high, the number of observation days that you bill out were kind of low because we're moving observation patients through very quickly as well. So they're not staying for 36 hours. They're averaging about 23 or 22 hours now. As far as net revenue, about 18.4% of the gross is what we estimate for the month, so about 4.9 million collectible revenue. That's about 300,000 behind the budget for the month. And then in the other revenue for the certified public expenditure, all the federal monies that we do get through the supplemental pool program, we are about 500,000 better than the budget for the month. And that gave us a net of about $12.9 million of net revenue. Budget was 12 3/4, so a little bit favorable. But on our expense line, salaries were well above the budget, about 430,000, as were our benefits, which run with salaries. And then our contract labor still remains pretty high, about $250,000 higher than budget. So those three, we were 200,000 ahead on net revenue, but we were almost $1.1 million behind in expenses for the month. So we incurred a loss of about $1.25 million. The budget was we were supposed to lose about 360,000. So I know that's quick, but that is in fact the performance for the month. A loss of about $1.2 million. Last month we lost about 750. So the first 2 months of the year, we're $2 million deficit. The budget was $360,000 loss. Questions? I'm sorry.
Can I ask on the expenses relative to budget? Is there what's the general reason for salaries and benefits being year to date 1.1 million above what was projected?
Sure. A lot of it is, I know Mr. Dietz understands we have to provide the budget in February, and we don't exactly know what new programs or clinic locations. So we acquired a pretty large clinic over in Metro Center with 3 providers, with pretty decent sized salaries and the staff to support those locations. So those were not budgeted, and we're benefiting from the revenue from that clinic, but the expenses do hit the bottom line, and they were not budgeted. So the other is we are in sort of a growth mode. We had a $4 million deficit basically on our request for Metro last year. So our goal was to figure out a way for us to develop and collect that $4 million on our own. So we're going to do the most we can with maximizing the volume that we already have, and we're trying to grow that new business. So the new imaging center at Bordeaux, the new clinic at Bordeaux, the urgent care there, those are all net new, and you got to invest before you start to see a return on those. That's the biggest impact of there. I mean, it's just bodies that aren't yet fully operational for the first couple of months. They're getting there, but they're not there yet.
So one operational, one kind of procedural question. So is the idea that the clinic that wasn't forecasted in the budget, will the revenue catch up to the expenses we expect, or are we going to continue to see a difference between higher expenses related to the clinic but not revenue to meet it?
No, honestly, 6 months. We've had that clinic for almost 6 months now, so I can't claim that anymore. In the first 2 months, when I was getting those physicians attached to our provider numbers, right, so we could bill and collect for them, definitely there was a lag. But since then, I can't blame that on them. That clinic produces more than enough to cover their expenses, but it was not budgeted, so it stands out on this line as being salaries that were not budgeted. So it is a difference maker.
And which revenue line item would the revenue from that facility
They'll be in that
to?
4.87. So they're embedded in that 4.87 million, that net revenue number. $4,878,152.
I see. Right. And so revenue generally is either inpatient, outpatient. Well, it's inpatient or outpatient.
Right, it's inpatient, outpatient, and then we have to sort of distill those down to what we believe is collectible. That's how hospitals typically do it. We have very complex reserve models, just like an insurance company, to estimate what we believe that to be. Usually Dr. Blackledge's revenue cycle team beats the number, but we use a 13-month sort of modeling program to estimate the net from the gross revenues that you see there. It's pretty complex.
So I guess the procedural question then is, so for the board to have an accurate picture of what the budget is that takes into account changes that may have occurred since February, is there an ability or a process to revise the budget so that we, understand that there's going to be additional expenses associated with the clinic that weren't part of what we knew in February, but so that we, as we're monitoring, we sort of have a picture of what the actual budget is opposed to the budget that we're looking at. Yeah, it's a lot of words, but can we revise the budget is a question.
I just say as a public body, it's difficult for me to change an approved budget that has been submitted and approved by the council. Could we do something one-off to share with folks from a reporting standpoint? We probably could do something like that. But I'm 35, almost 40 years. I've never changed a budget midstream while I'm in the middle of it. I don't know what council would think or Metro Finance would think, but we have not done that, Mr. Esquivel. Certainly we could make our efforts to help identify that.
Yeah, I appreciate that.
Sure.
Changing the budget of a governmental body is it's partly why I asked, and I will leave it to the finance committee. If further reporting though, not changing the approved budget, but
Correct.
reporting that takes into account things that were not expected when this budget, I feel like the board would have a more accurate view as to how we're tracking, just for reporting purposes, separate from the budget itself.
Okay, sure. Other questions?
Have any more questions for Bruce? Finance team had a chance to review as well.
We've reviewed the budget and unanimously recommend that we move this to the full board for approval.
All right, I'll accept that as a motion. Can I get a second? All in favor, vote by the sign of aye. All opposed, ayes have it. Thank you, Bruce. We will now have the CEO's report. Dr. Webb, you are recognized.
All right. Thank you, Mr. Chair. I'm going to give a little bit of information on connecting the dots on how the existence of the public hospital actually operates and where we are at this time. Article 2, Powers 15 in the 1962 City Charter states that the City of Nashville is responsible for the care of the sick, children, the aged, and the destitute, which is the indigent population. So in 2025, 1.8% of the city's $3.2 billion budget was allocated to Nashville General Hospital to care for the indigent population. That is 1.8%. That speaks to the issue of the liability of the hospital. It is 1.8% of the city's overall budget. The point is that the care for the indigent at Nashville General Hospital is a small percentage of the total expenditures of the city. Nashville General Hospital offers the care that it delivers at a fraction of that of other hospitals in Middle Tennessee when compared to them. Nashville General Hospital provides evidence-based care delivery in an integrated setting. It also utilizes programs that reach beyond the hospital and into the community. Nashville itself and the state of Tennessee are financially very healthy, but there's a health care outcomes challenge. Research and the data shows that Nashville ranks at the bottom of health outcomes when compared to other growing and thriving metropolitan areas. Now, these outcomes will tend to disproportionately affect people of color and marginalized populations. To better address these issues, Nashville General Hospital has extended the services that it provides beyond the footprint that historically existed. You heard some of the marketing report that mentioned the Bordeaux presence, which was previously a healthcare desert. Now it has a primary care facility, it has specialty, it has a freestanding imaging center, and it has a weekend urgent care center, all in an area that was a healthcare desert. So some of the newly implemented services includes the no-wait ER, the weekend urgent center, behavioral health, women's health, midwifery services, community care coordination, and the food pharmacy. So this is really an example of the critical nature of healthcare in Nashville and how it's being addressed by Nashville General Hospital. So the takeaway here is that at 1.8% of the budget, the city's total budget, which represents $59 million, which also represents a $4 million deficit in what we actually projected and provided to the city, that would be the cost of the indigent population. So in so many words, the things that you're seeing that we're doing, we're pretty aggressive with building and growing, and we spent many hours working on putting together a revenue growth plan to make sure we're targeting at $4 million. And so our goal is to assure the hospital, the city, the staff, without reducing FTEs or cutting salaries or reducing hours or laying off, that we backfill that deficit. And that's what you see. Now, I would say to the questions that you were asking, Mr. Escobar, we have to be mindful of the downstream activities of our clinics. Those primary care physicians that are in those clinics are not the highest paid physicians, the specialists are. So, but the specialists don't survive without the primary care. So to have a robust primary care environment means that you can plan to grow your volume on your specialist side, which is where your revenues are truly generated, but they can't happen without the primary care provider. So it gets to be a very complex work of making sure that the synergy is there, that the relationships are there. So we're still working on building those relationships and making sure that we're maximizing that flow of activity. So it just kind of gives you an overview of where we are and the criticality of the public hospital and the fact that the city is able to get this service at a fraction of the cost. Happy to answer any questions that you might have.
Forgive me, Dr. Webb, but you told a story about weaving things together, but if I understand correctly, what you started out saying was that we have a charge from the city to serve a certain segment of the population, and we are asked to serve that population and are given some level of reimbursement by the city that does not cover the cost that we have to serve that community. Is that correct?
Yes, we were given less than we requested. I have seen over a 10-year period, I've certainly seen where it was a lot less given. So I didn't want to make this totally about that deficit because I think we can overcome that. That was really more educational than voicing a complaint about it. Of course, if we are given $4 million less than what we asked for, we're essentially subsidizing the city by $4 million, which is not all bad, but would be nice to have it. So, but that wasn't the point of I just wanted to make sure that we're all aware that that is the case. Because I think in many instances, we're not fully transparent and communicating with our board, partially because of a reluctance to share too much in the public that could be detrimental to certain parties or stakeholders. And because of the Sunshine Law, we only get around that when we have strategy sessions.
Thank you, Dr. Webb. Any more questions or comments for Dr. Webb? All right. Well, we'll go into the chair's report. I just have a couple of cleanup things, particularly around some of our committees that we need to get cleaned up. Currently, right now, we have Ms. Smith and Mr. Lesser and myself as a ex officio member for the CEO Performance Committee. And I need to add a third person, and I was going to see, or I need to do two things. I need to see if we can ask Dr. Fagans if she would join that committee, and then also if Smith would be willing to serve as the chair. And I I would put that as a motion and ask for a second, and then we can approve that committee. Thank you. That's a motion. I need a second. The motion is that we would I'm making a motion, yes.
A second.
All right. All in favor, vote by the sign of aye. All opposed. Second thing is we need to, in our new bylaws, this will be the person kind of replacing Dr. Burley. We need the special medical staff oversight person, and I'd like to recommend Dr. Miller, and I'd like to do that as a motion as well, if I could get a second. All in favor, vote by the sign of aye. All opposed? Thank you. Finally, I just want you to note on your calendars that we typically meet the last Thursday. However, because of Thanksgiving, that will come a little sooner. So just note on your calendar that we'll be meeting November the 21st will be our November meeting, okay? And then at the November meeting, we can determine what our next meeting will look like for December. All right? I think that concludes our agenda. If there are no other, I'm sorry,
Mr. Chairman.
Yes, sir.
At the last board meeting, as referenced in our notes, I requested a strategy session to discuss the strategy associated with our political agenda. I don't know if you've had the opportunity to schedule that yet.
I have. I talked with Ms. Lester. We're going to move that to the November meeting. We wanted to have time for the bylaws on this one. So, any other questions or comments? All right, I'll entertain a motion to adjourn. All in favor, vote by the sign of aye. All opposed, we are adjourned.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.